Welcome everybody to this weekly webinar that we're going to be hosting on the COVID-19 situation going on in the country. Like to thank everybody that took the time to join us today, and I'm sure we're going to be having a few more people join us. It's my pleasure to welcome Chief Gary Ludwig, the current president of the International Association of Fire Chiefs. Just want to let you know, since we're doing this voice over internet, make sure that your speakers, or if you have a headset, make sure that those are turned up and that you have your volume on. Just want to let you know that. If you have any difficulties while you're doing this, make sure that here's a phone number and here's a web address for you to try and check into. We won't be able to actually answer any questions while we're on with regard to this, but just want to kind of give that to you. So it is my pleasure to start this off with Chief Gary Ludwig, and he's going to welcome you into the webinar.
All right, thank you, Dave. And I appreciate everybody being online here today. As Dave said, my name is Gary Ludwig. I'm honored to serve as the president and chair of the board for the International Association of Fire Chiefs. I want to thank everyone who is joining us today on the IAFC Coronavirus Task Force webinar, either directly or later when you listen to the recording. We also want to thank FirstNet for sponsoring this webinar. The IAFC represents the leadership of 1.2 million firefighters and EMS personnel. Our task force is chaired by Chief John Sinclair, and he has a large spectrum of experts on the task force, including chiefs with knowledge of emerging diseases, representatives from the IFF, AMR, United States Fire Administration, the IFC Data Technology Council, those from private industry with knowledge of supply chain issues, plus many others. This is our second webinar conducted by our Corona Task Force to keep our members and the fire service and EMS up to date on the latest information pertaining to the coronavirus and its impact on emergency services. There is no doubt that we are on the front lines of this battle. We have several goals. First is the safety and health of our firefighters and EMS personnel. Additionally, we wanted to be able to point you to the resources and to keep you better informed. We have a webpage for all these resources and a dashboard that we encourage fire departments and EMS agencies to provide data so that we can track personnel who have been exposed, quarantined, or diagnosed with the coronavirus. We need fire departments and EMS agencies to input the data so that we can get the big picture of the impact of this pandemic on emergency service agencies. Currently, our IFC lobbyists are up on Capitol Hill using this data to argue for funding for emergency services in the third stimulus bill. Hopefully that will come out from Congress. Unfortunately, it failed today in the Senate, so hopefully they will get their act together, quite frankly. This webpage can be found for the resources in the dashboard at iafc.org/COVID-19. At this point, I want to turn the webinar over to my good friend of many years and our chair of our task force, Chief John Sinclair. John?
Thank you, Gary. Can you hear me?
I can hear you fine, John.
Okay. And thank you, David. My part is going to be short, is simply because I want to get to Dr. Augustine. So that everybody knows and understands, last week we had a request from a member to have us vet the process by which we decon bunker gear and SCBAs. We put that out between the Hazmat Committee and Safety, Health, and Survival, and we will have that guidance out soon as it needs to be vetted through the task force. They put out very good information. We're continuing to vet the information. And I think that it is also important that we understand that we've established Dave Becker at IAFC headquarters as a staff liaison for this, and he's going to have a email covid19tf@ifc.org, and we will put that up on the website so that everybody can know. We need to get your questions answered. So as you get issues in your community please let us know. We had the Surgeon General come on today and talk about the fact that things are going to get bad over the next week. I certainly would agree with that. I think that many communities are going to see an uptick in patients, positives, and also, unfortunately, the death rate is, or not the death rate, but the number of deaths is going to go up. We're in this for the long haul, folks. And to that extent, I really want to focus this back to your basic ICS training or incident management training. This is a long-term event, and one of the things that we're going to have to do is look at this from the perspective of just like we would a project fire or any other long-term event. Take a look at your ICS functions, and one of the things that I would urge you to do immediately, if you haven't already, is begin to get somebody in your organization and begin to start tracking the financial impact of this. As President Ludwig said, we have very capable people up on the Hill trying to get some federal relief on this. The President has called this to be a disaster under the Stafford Act, but you're going to have to justify your expenses. And so to do that and start tracking those expenses early on. If you have not set up in your local agency or a regional process, I would urge you to start looking at A, taking this very seriously, and B, begin to work with your neighbors and establish a community-based approach to this, because like I said, we're probably 8 to 10 weeks. And that's just John speaking. That isn't anybody from CDC or HHS. But studying these for the past 25 years, my guess is that we're sometime into July before this begins to slow down. So those would be my opening comments. And I know that Dr. Augustine has a number of recommendations for us. So I would like to go and hand this over to Dr. Augustine.
Chief Sinclair, thank you. Can you hear me, everyone?
Absolutely.
Yeah.
Thank you. It has been a very eventful week in this country, and we are now beginning to realize the impact in the United States related to COVID, and COVID-19 is the appropriate abbreviation that will be used from here forth in discussing this. What we have learned is that we are at the community spread level of functioning in this country. The containment did not work because this disease hides very effectively. And in hiding effectively, the symptoms that are present in people early in their presentation are very broad and hard to identify. And as we get across the country into allergy season, be even more effective in hiding. We also know that we are now presented in the EMS system with late patients who are getting ill as a result of the virus. And we're going to need to take increasing in care and managing those people in the emergency medical service system. We're going to start like we did last week and talk first about protecting our people. During the battle, we cannot lose our forces. So in looking at the discussion, the questions that came from you and the medical director discussions that have taken place in the last week, here is where many agencies have moved towards. Number one, the stations where equipment is based and where people are based have to become sterile. And you're going to have to shut down your stations if you have not done already. And then as your personnel arrive on shift or for a response, if they're volunteers, they have to be checked to see if they are ill. The check for the illness, it first begins with, are they having any symptoms? And then second is a temperature to see if it's febrile. Very important if we're talking about our stations being sterile and our people being sterile, that we keep our apparatus and our supplies as clean as possible. That means not bringing dirty equipment back into the station, and if there's anything that is marginal, leaving it outside the station until it has been disinfected. Some departments have moved to station-specific scheduling, and what I mean by that is where there are station personnel that usually would move between different stations, that those personnel be locked into particular stations so that we don't have the disease moving from station to station with flex people. In some situations, that involves significant hardship on the department, but nonetheless prevents spread of the disease moving from station to station. There's a very important health monitoring process that needs to take place, and it begins again with station checks at change of shift, where each staff member is checked for symptoms first and then a temperature. And we're going to talk about return to work strategies a little bit later, but it would be important for you to develop return to work strategies that straddle the existing 14-day schedule, or in the future moving to a 7-day schedule. Please move ahead. Our symptom problem with this disease is that we don't have a herald symptom that relates to coronavirus. Unfortunately, it begins with symptoms like I don't feel well, I feel achy, I'm having difficulty breathing, I have a runny nose, sore throat, dry cough, which again in many areas of the country would sound like an allergy presentation. And then typically later in presentation is when fever is coming. So we begin thinking about our own people having those symptoms, but then in the 911 system, asking about those symptoms so that we can begin to alert crews that are moving to that incident site. What is now happening in the last week is that many patients with known COVID disease, they've already been swabbed, their results have come back positive. If they are not very ill at the time, they are sent home from the clinic or the emergency department with known COVID disease. If that information is available to the 911 center, it would be very important for that information to be passed on to the crews. Most of the people also who are home have a caregiver. And if one of the caregivers gets ill, it is anticipated that that person would be positive for COVID as well. That's how effective the spread of this organism has been. Therefore, if there's a known COVID that this individual is being taken care of by other people and they get ill, it is anticipated again that we will need to take full protections. The typical language that's being used is over the dispatch sequence is respiratory protection indicated, rather than using other terminology. Please move ahead. So our usual points of failure are occurring again in the system. And for those of you who've worked all other kinds of disasters, you know where the health system begins to break down. First of all, we need to have care for the families of our people, and that is daycare or senior care in certain circumstances. And our personnel, in order to be able to work effectively, need to know that their children or their parents that need care are receiving that care. And therefore, it is very important for departments and chiefs to look for safe sites for those individuals. That allows our personnel to concentrate on their job at work. The weak points in the community: nursing homes, group homes, the homeless, and home health care agencies are beginning to fail or show signs of stress. Nursing homes have, in many cases, shut their doors, except when they have a patient who needs help, and then they want EMS to respond, move into the home, take care of the patient. We have asked as many systems as possible to have the nursing home, senior care facility, extended care facility move the patients to a transition point that is outside the home itself, so that then our personnel are not moving into a senior care or extended care facility, and at the same time protecting our people from what may be going on inside that facility. Group homes, same way. Homeless populations, same way. What we have noted in the last week in a number of my agencies is a rapid increase in our lift assists as home health agencies are having trouble fulfilling their responsibilities taking care of people who are marginal at living at home and therefore need help in the usual transfers from bed to wheelchair, et cetera. So we have had this happen in numbers of disasters before, whereas the home health agencies begin to fail, we get a rapid increase in calls for assistance. The two bottom points, very important. We're facing medication shortages as both India and China do not send forth raw materials that are needed for drug production in America, and that's resulting in an even broader range of drug shortages for us to manage. And then all of you are aware that PPE is in short supply. Let's move to the next slide and talk about PPE. The strategy now in personal protective equipment is conservation and moving towards reuse of some of the equipment. The most important piece of PPE is a mask on the patient, and that mask is very effective in reducing the spread of disease that usually comes from nose and throat secretions from the patient. Therefore, putting a mask on the patient, and that could be any form of mask, including cloth masks, that are comfortable and safe for the patient. Very important step number 2 is minimizing the personnel that come into contact with the patient, and that means within 6 feet of the patient. Within 6 feet of the patient puts our personnel at risk if they come back with either coronavirus or many of our other standard infectious agents. 6 feet is a great radius, and there's typically only a reason to put one person within that 6-foot radius to begin with. Within that 6-foot radius, N95 when available, or surgical mask on the providers, disposable gloves, and goggles or a face shield of some kind to protect the eyes from getting any agent coming off of the patient into our providers. If the patient is coughing or sneezing, we have to add protection for our clothing, and that's gowns or coveralls. And many of you have moved beyond the gown stage because gowns are not very effective in the field when we're trying to work around people crouching down or bending down in a medic unit during transport. So coveralls are a great idea. For high-risk encounters, which means aerosol-generating procedures, it is mandatory that N95 or higher be used and that we cover the clothing and we cover the head. Particularly in regard to airway interventions, we need to make sure that we cover people as the patient at any point may cough and spew the viral agent. A very important discussion this last week has been about the use of nebulizers. And nebulizers, as you know, create a vapor path, and that vapor path can contain any infectious agents. Many patients need nebulizers and are only going to relieve their bronchospasm and part of their respiratory distress using nebulizers. Nebulizers, in their effectiveness, are a very effective way also to spread the disease. Therefore, if nebulizer treatments are going to be used, they should be used outside in an open air environment. The crews should be kept upwind from the patient, more than 6 feet away, and because the droplets that come out of that can drop onto the patient's clothing, it's a great idea if you take one of their sheets, put it over the top of their clothing. At the end of the nebulizer treatment, you carefully take that sheet off of the patient and leave it there for the family to clean or take care of. So a great effective way still of being able to use nebulizers is in an outside open air area, more than 6 feet away, covering the clothing of the patient and leaving any droplets that may come as a result of the vapor treatment there at the scene. Next slide. All right, disinfection. The most important part of disinfection is don't infect anything that doesn't need to be for patient care at the time. Therefore, any equipment can be kept 6 feet away. Our radios and computers should be kept 6 feet away with somebody else using those devices, not the individual who's within that 6-foot radius caring for the patient. There's discussion about how to clean radios and computers, but frankly, the best formula is don't put them in the dirty environment to begin with. Don't carry any dirty equipment into the back of any of our vehicles, which includes either an ambulance or a fire vehicle. Therefore, red bags should be available and useful, both for equipment that we're going to dispose of, as well as any equipment that we're going to clean and reuse. Within the ambulance itself, it is very important that disinfectant cleaning be done on any high-touch surfaces, any surfaces that are obviously dirty, and horizontal surfaces within the ambulance. Horizontal is what catches the droplets that come out and away from the patients that may contain the virus in a quantity and a form that is infectious to our people. So those are the priority surfaces for cleaning in the back of the ambulance and to keep away from our people. Again, having everything clean before you leave the hospital and before personnel get back in the vehicle to return to service. Next slide, please. Very important part of our last week has really been the issues around quarantine and isolation. And unfortunately, we're probably numbering in the thousands now the number of fire EMS providers that are in quarantine. And quarantine means they are not sick, but monitoring for symptoms versus isolation. And isolation begins with I, as illness does. So someone who is ill with symptoms of COVID is considered in isolation. In your pre-plans, chiefs, we need to think through what are appropriate quarantine and isolation locations, sometimes in the individual's home, sometimes in a facility that is available to us but not dangerous to other people. And in some cases, those can be our own facilities that are kept out of service for the public. We are learning about the logistics needed to support our member who is in quarantine, both physical and mental, since this is very stressful for many of those people. If proper PPE is used, then there is no risk or minimal risk of our personnel. And even in situations where the patient is high risk for the disease, proper use of our own PPE puts our member in a minimal risk position, which means they monitor for symptoms on duty for 14 days to begin with. It is important that you develop an incident tracking process and the forms that go along with it so that you know what crews and what individuals on those crews have been exposed to people who later on come back as being COVID positive. So an incident tracking system, very important. And then within that incident tracking system, making sure that you know of the 5 individuals that came to that scene, which ones were within 6 feet of the patient and which ones were not, because our attention has to focus on those individuals that were within 6 feet and their use of PPE. So many of you have gone to tracking the PPE and the distance from the patient and any exposure from the patient that occurs. I would suggest that you develop a 14-day personal health form. Nothing complicated here, and I think I have an example of it to post up here next, where we're asking the person twice a day to monitor their health and to describe any symptoms that they may be having and that their temperature is taken. This form could be used for simple self-monitoring of an individual who is staying on duty but has been exposed to a high-risk patient. This form could also be used for a member who is in quarantine at home or another site. And the recording of the information here lets us know, again, this individual belongs remaining in a quarantine state and it's not moved into symptoms and does not need to be moved into isolation and receive a medical evaluation themselves. These are the symptoms that we believe still relate to early presentations. There's been discussions about other symptoms, including diarrhea, including loss of taste and smell, and many other things that you're hearing across the social media. As best we can tell, these symptoms that are offered here on this form are the early indicators of this disease, but you consult with your medical director and your local public health. If this changes, then you have a blank space there that you can put additional symptoms in. Last slide, please. Our policy priorities ongoing for the system revolve again around community spread and about the symptoms that we're worried about both in the patients that we deal with and our members themselves. We are moving into a phase again where the patients may be at home with known disease. And if so, we are going to get calls that these patients now have a fever, they're in distress, they need an airway intervention, they need EMS and rapid transport to the appropriate receiving site. Next slide. Our priorities moving forward. Telehealth, there's been rapid expansion and discuss about telehealth and linking of pre-hospital care providers to public health experts or to emergency physicians and others. That has led us to think through what are the no response calls that we may be pushing into our 911 system, and when are no transport processes an option for us in the disposition of the patient. A very important policy priority is that we get PPE and the medications that we need for fire and EMS use in the field as we face more and more of these patients. EMS surge capability. Many of your states have relaxed rules and regulations. They've allowed portability of licenses between states. They have moved back expiration dates for existing people as we don't have time to be doing a lot of paperwork right now. Very important that you keep in track with the emergency departments and your medical director about modifying CPR and doing termination of resuscitation if we think this patient is very high risk. A unfortunate statistic that we've known for many years is that patients who have a cardiac arrest as a result of an infectious disease have very, very poor outcomes. And with those very poor outcomes, we oftentimes will think through termination of resuscitation earlier than if we think this is a primary cardiac event that has resulted because of ventricular fibrillation. That may result in us having less people exposed for shorter periods of time in an effort that will not be fruitful for the patient. And therefore, we are moving very quickly to share information about how we're modifying CPR, modifying airway interventions, moving towards more use of supraglottic airways, for those of you familiar with that term, away from doing endotracheal intubation, which is a much higher risk procedure. And then moving quickly through the resuscitation to the decision-making phase where we can decide appropriately when to terminate the attempted resuscitation. I wanted to make you aware as you watch the news and we think about the American health system and those communities that are ahead in this disease of many of us. The first failures are going to come in the ICUs, and then from the ICU, the failures will move into the emergency departments and then out to the community. That was what happened in Italy, and our American health system leaders are trying to pay attention to what is happening in Italy and in other places where the disease has spread more widely within America. So it's very important for you as fire EMS leaders to make sure you keep in touch with the hospitals and are listening as they begin to stretch their resources within the hospital, because that's then going to move to the emergency department and then out into the community. I appreciate the opportunity. We will keep up to date on what is going on both medically and procedurally with EMS, and very important that we share those best practices. So you should keep in touch with IAFC and with this important task force that is sharing information with you. John, I'm going to turn it back over to you. Thank you for this opportunity.
Thank you very much, Dr. Augustine. The one thing that I want to revisit just a little bit is the PPE and the supply chain. We'll get to Mr. Kapoor here in a little bit. But the one thing that we need to make sure of, and the IFC staff made sure of this last week at the federal level, is that HHS has determined that we are part of priority one. The issue is that while we are under the federal system priority one, for PPE under the Strategic National Stockpile. Once it gets to each state has its own ability to change the distribution. So for the fire chiefs out there, it is vital that you get with your state chiefs and that you have this discussion at the state level. I'm in the state of Washington. We addressed this early on, and we made sure that EMS was part of Tier 1, Priority 1, however your state classifies this, but you have to have the ability to get the PPE, especially masks, early on. So we've done what we can at the federal level and getting that guidance from HHS, but we need each of the chiefs out there in each state and the protectorates and the territories to get out there and be proactive with their state EMS offices or your state departments of health and get EMS to the top of the food chain as it relates to PPE and the Strategic National Stockpile. So with that, I'm going to hand it back to Gary, and I think that he's going to have either Ken or Amit talk next.
All right, thank you, Ken. I'm sorry, John. Thank you very much. I think Amit is up next on our batting order here. So, Amit, are you ready to provide some great information?
I'm here, Gary, and I appreciate letting me speak again about supply chain and giving the industry perspective to everybody who's out there. So I don't have any good news or brighter news. And supply chain, they're having similar issues in terms of our workers having COVID-19 or suspected or presumptive, and then we're putting our folks into quarantine or isolation. Thus, meaning our manufacturing capability is reducing on a daily basis. And this means that it's not a short-term duration isolation, it's a long-term. We're talking 14 days. And that's 14 days, that's a question mark. And I think we've been talking about that quite a bit. There has been guidance from the federal government, so DHS has given manufacturers who are responding to EMS and fire critical, it gave us essential guidance for critical infrastructure, and there's been a designation for suppliers to keep working and keep operational as much as they can if a state does do a shutdown procedure or a non-essential worker stay home procedure. This is happening in the United States. The issue we're having with some of these manufacturers is it's not being communicated to them. So supply chain has been hit pretty hard. We're seeing this in California, New York, and Illinois already. And so contact your supplier, contact whoever is your current suppliers. And the key is going to your procurement officers and having a discussion with them to make sure that they're aware of that supply chain, that you usually can order an N95, some gowns, drop a hat, and turn on a faucet, not anymore, and to please talk to your supply chain. The National Association of Manufacturers is working with the White House. I'm working with them on a daily basis on giving them supply chain updates, and I'm getting that back. Current items that they're looking for are not for today. The items that we are now sourcing and they are looking for are for a week, 2 weeks, and into 10 weeks from now. So the items are ventilators. We're looking at getting at least 10,000 put together within the next couple of weeks. N95s, and that's been beaten up quite a bit. N95s are short. 3M, Honeywell, and there's a number of manufacturers who are coming online and being able to push out 35 million masks or more a month. So everybody's drawing from the same stockpile, and HHS is prioritizing. So it was stated that states have the designation to decide what they want to do with their N95s. Reach out to your governor's office. If you can talk to your state congressional officer as well and say you need priority. What's happening at times, what we're hearing is there's nobody listening, and it needs to be put out to a lot of folks who are up in the state level to address with them that you need items. Other items that they're looking for within the federal government and state governments are vital sign monitoring systems. We're finding that people are needing power cord cables because they're made in China, or raw components. This is something that you guys need to look at what your inventory is for example, ECG leads for your heart monitor and see what is currently in stock and what your burn rate is, and prioritizing that burn rate. Gowns are in short supply, understand. They are coming back online. We are seeing an uptick in gown manufacturing within the United States. What we're also seeing is that some of these items like face masks, N95s, and gowns are not medical grade. This needs to be a discussion and a decision that's going to be going on a daily basis on whether they're going to start allowing the use of uncertified products. Right now, do not, if you can resist the urge, do not do that. Follow CDC guidance, check NIOSH's website. If the N95 manufacturer that you are looking at, they have a TC number on them, it starts with TC, the 84A, you can search this on NIOSH's website to ensure that that N95 is a certified N95. State governors are working with countries like China, India, and other domestic manufacturers to try to get as many N95s in from outside of the traditional 3M and Honeywell. So look for that coming down the pipeline. We are looking into what state assets are out there right now. We are asking, there's a lot of asks from governors and state local officials. We're asking them if they can put together an inventory list and help communicate that out to fire departments, EMS, and other folks as well. That's not going to come online soon. It's taking a little bit to come on. The White House is collecting a supplies list. I think a couple hours ago, Peter Navarro was on. He's leading the manufacturing and the industry liaison side to the industry and working with Defense Logistics Agency, seeing if DoD can supplement some of the supplies that the national stockpile might not have. We're trying to get the red tape. There's a lot of red tape that traditionally has been there. I'm not saying that's eased up, and we're trying to push through that. This is procurement laws. This is lifting of regulations. It's taking time. One good thing I'll tell you that's come out is FDA is moving very rapidly. New test kits are coming on a daily basis. FDA is approving emergency use authorizations overnight. We've seen every day a number of kits come online, and the flood of kits are coming in from China, from Korea, and also domestic sources. There is guidance that's coming out on reuse and how to resupply from the federal level. On reuse, I mean on reusing PPE. This is a very touchy subject, and I know that a number of people follow CDC guidance right now. The mode is not into changing practical and operational guidance that we're trying to give. We want to make sure that people are following CDC guidance. Dr. Augustine can talk about that as well, what he has seen. But please, if you have to go to practical and operational changes of what PPE you're going to be utilizing, or if you're going to be reuse or sterilization in different manners, and I've heard a lot of different methods of trying to disinfect N95s, we don't know if that is actually going to work. We don't know if NIOSH is approving it. There is a test process that NIOSH has to apply to ensure that N95 still gives you the same protection, or it's false protection, and you will be getting sick again. The guidance will be coming out on how to decon bunker gear from the IAFC, and it's very practical, and it uses the same technology that you're already putting into use. My final tip at the end of this call, leading this webinar, is please control your burn rate. Understand what your burn rate is. We're seeing this as a major issue across states that have a high number of coronavirus contamination. It's the states who don't have it yet. Look into what your burn rate is currently and what will be forecast into the future, and try to control your stock. That's the best advice I can provide out of here. Thank you, Gary.
Thank you, Amit. And we're blessed to have you and Dr. Augustine on our task force. There's no doubt that you bring tremendous value and tremendous and outstanding information, phenomenal information for our members and those in the fire service. The next one we have up is another one of our rock stars, and that's our Government Affairs Director, Ken LaSala, who's been burning the midnight oil down on Capitol Hill these days, trying to work with Congress and some of our other association partners on ensuring that we are well represented on this third stimulus bill, hopefully whenever it comes out from Congress. And so, Ken, I also want to thank you. I know you and Evan and Brandon are doing tremendous work down there, and and representing us quite well. So, and I know you're burning the midnight oil. So I'm going to turn it over to you, Ken. You can provide these legislative congressional priority updates to our members and those on the webinar. Ken?
Thank you, Chiefs. I appreciate your guys' time today. A couple of things. First, I wanted to just talk about some executive branch issues. First thing, most important, is the fact that FEMA is now the lead federal agency for COVID-19 response. They're working with HHS, but hopefully it should make things a little clearer. FEMA's actually been sending teams out to the different regional offices. So I definitely would recommend that you touch base with your regional administrator regarding COVID-19 response. In addition, COVID-19 expenses can be reimbursed through the public assistance program. FEMA has a guidance, which we actually have on our website. That's the www.ifc/coronavirus or www.ifc.org/COVID-19. And I definitely recommend you take a look at that guidance because FEMA has said that they can reimburse things like overtime and backfill and also materials that have been used in COVID-19 response, and then even apparatus transit or transport costs. All that has to be followed using the ICS forms, and they're all there on the website. So either you can go to the USFA page, or I recommend going to the IFC page where we have everything located. Moving forward, there's a couple of different issues that we're starting to take a look at. First, Chief Ludwig has been up with the executive branch. This was about a week and a half ago. He actually met with folks from both the White House and the Assistant Secretary for Preparedness and Response over at HHS. And the big things we've been really focused on are first getting supplies to our members, and then two, making sure that our members are getting tested. One of the really big issues we have is priority testing for first responders. It's important, as Dr. Augustine said, for firefighters in the field, if they're exposed, to get them tested. There's some about having firefighters quarantined for 14 days and how that's going to lead to staffing challenges for the fire department. So the one thing we've been pushing the Hill and also the executive branch aggressively is to make sure that fire and EMS agencies are priorities for getting testing. Again, I talked briefly about the need to get supplies to the to the local fire departments. And I think Chief Sinclair gave a really good analysis of making sure that you check in with your state emergency managers and state public health offices to make sure that the supplies that come from the national stockpile are going to local fire departments and EMS agencies. The other big issue we brought up with the executive branch is the need to notify about drug shortages. This is important so that way fire departments are making decisions about what to do if there are shortages, and checking with their medical directors to find out if there's substitutes and things like that can be done to address some of those issues. One issue we had was we heard that there might have been a drug that was in shortage, and the FDA was not announcing what it was. So now we're working to try to get the FDA to do a better job of at least letting fire and EMS agencies know when there's drug shortages. Moving on to talk about some of our congressional priorities. We've actually been dealing with the stimulus bill. Just so you all know, like Chief Ludwig mentioned, the Senate tried to get cloture on a stimulus bill today. It came up short. The Republicans came up short, so the Senate Republicans and Democrats need to continue their negotiations. Over on the House side, the Democrats are talking about introducing their own bill. That actually would be $2.5 trillion, including there would be some funding in there for local fire departments for dealing with the COVID-19 response. All this plays out, and obviously we'll be following all this as it occurs, update you, especially when the bill passes, about what happens and what the COVID-19 stimulus bill means for local fire departments. As you, what we're working on going forward, is we have worked with the IFF to actually ask for $2 billion for the AFG and SAFER grant programs, $1 billion for AFG to pay for supplies and equipment, and then $1 billion for the SAFER grant program to pay for issues like backfill and overtime. What we're trying to do basically is repurpose the AFG and SAFER grant program to get funding directly to local fire departments. With that, the other things that we're doing is we've asked Congress to remove the local match requirement, and we've also talked about removing the peer review process. That way we could get funding to local fire departments faster. We're obviously aware of the concern that if money is given straight to the states, it doesn't go down to local agencies. So that's something which we're working on. We've also talked to Congress, obviously, about the importance of priority testing for first responders and notifying local agencies when there's drug shortages. Moving on, some of the other things we've talked about are the needs for protecting jobs to your firefighters. One of our concerns is the fact that if a volunteer fire or EMS officer is responding to a patient is exposed to COVID-19, they would have to be quarantined for 14 days. And the question is, what does that mean for them? So one of the things we've made Congress aware of is the need to make sure that volunteer fire and EMS officials receive the same protections as the National Guard receives when they're deployed. So that's something which we're working on. Also, there's a Volunteer Responder Incentive Protection Act. For this year, only calendar year 2020, a volunteer firefighter can receive up to $600 in state and local incentives, and then any type of property tax benefit, and the federal government cannot tax it. So one of the things we're looking at doing is trying to extend this past 2020. We also, to carry on some of the things that Dr. Augustine talked about, we're talking about doing important things to improve mutual aid, because fire departments are going to need help and assistance, especially as their members and staff are quarantined or infected. So one of the things we've asked about is trying to temporarily waive the state EMS licensure so that licensed fire and EMS personnel from one state can move over to the next to assist. The other thing too, there's been a lot of discussions about whether or not there might be restricted regions. The president has said even today he was kind of cautious about that. We've told the administration that if they do end up having to decide to restrict transportation in certain regions, we will fire and EMS personnel have the ability to have safe passage through there. That way they can aid the local fire departments that may need assistance. And of course, the last thing we're working on is need to protect communications in the major cities. The T-band issue is still out there. The FCC has been directed by Congress that they have to auction it by February 2021. And so basically what we've done is we've got the fact that 11 major metropolitan areas, including New York and Boston and DC and Houston and Los Angeles, are all affected. Many of these cities are now, especially New York City, is having to deal with record numbers of COVID-19 patients and some of the after effects of that. And so we've asked Congress to end the T-band auction requirement. And I think there is some interest in trying to do that on the Hill, but we'll have to see what's in the final bill. That's my update, and I'll be glad, Chief Ludwig, to turn it back over to you.
Thank you, Ken. That's some wonderful information, and I appreciate all the work that you and Evan and Brandon are doing in our down on Capitol Hill to represent fire and EMS. And let's hope that there's $1 billion there for AFG and $1 billion for SAFER, and we also get priority testing. So, Dave Becker, are you online? Were you gonna? Did I see on the agenda you're supposed to give an update on the operations center or NMAS operation? Is that correct?
Yes, sir. So the IFC has stood up a emergency operations center, and it is fully operational at this time. So we have quite a few of the staff are working on different areas and putting things together. I want to encourage everybody again to keep an eye on the dashboards that are up on the IFC website. impact dashboard and then the personnel impact surveys are both things that you should be looking at. And then today, we're getting ready to put together and have a survey up there on fire and EMS force protection for PPE. And so this is a survey that you can give us some feedback as to whether or not where you're at, whether you're depleted now, you're going to be depleted in a couple of days or a week. And then that gives us, gives people the information to be able to help go and advocate for more supplies specifically. So I really want to encourage you to look at the opportunity for that force survey force protection survey when it gets posted later today. And then up on the screen right now is the email for the task force. It's COVID-19tf@ifc.org. One of the things that I would tell you is that one of the things that, in talking with Chief Sinclair this weekend, was I think one of the things that will be helpful is that if you have specific questions, and not that we'll wait till next weekend, but there may be certain things and there may be certain topics that will help drive some of the information that's put out on this webinar. So we're going to be doing another webinar next Monday, and the plan is for the foreseeable future to be doing these on Monday about 4 o'clock Eastern. But so send those questions in. I'm going to be looking at these emails all day, every day. And then if you also, one of the things that I think will help us down the road too is if you have best practices or policies that you want to share, some examples of some of the things that you think are unique or might be useful to somebody else. This would be one of those places that you could do it. I've already seen some of the things that are on knowledge, and not everybody may be going to knowledge that, but that's certainly another place that you can help let people know what you're doing out there. So I think that's one of the things that this is one of the things that we wanted to kind of put out there, make sure, and as Chief Ludwig mentioned at the start of this, this is the email address that will specifically for the task force, and like I say, what I'm working on is between staff and the IFC and the task force is kind of help providing and funneling information into both, primarily to Chief Sinclair, and he'll make the necessary notifications to everybody else. So I do want to thank, make sure that want to thank FirstNet, built with AT&T, for helping sponsor this. Certainly, those are, that they help us be able to provide this service to you all, and so for that, I'll turn it back over to Chief Ludwig to kind of end up the webinar.
Thank you, Dave. I just want to thank all our panelists today who just provided terrific and outstanding information. I want to thank Dave Becker for coming up to IFC headquarters to help us during this very difficult and challenging time. I want to thank Chief Sinclair and all those on our task force who are doing just yeoman's work. Finally, I want to thank our interim CEO, Rob Brown, and members of the IFC staff who are working many long hours and weekends. It's unfortunate, but it looks like we are in this for the long haul. As Dave Becker said, we have established an operations center at the IFC offices and continue to engage at all levels with our federal government, including the White House, FEMA, HHS, and the Department of Homeland Security. We also continue to partner with our fire and EMS associations that we work with to show a united front with many of these federal agencies and Capitol Hill. As Dave said, during this ever-fluid situation that seems to be changing hour by hour, the IFC Task Force will be doing these webinars every Monday at 4 p.m. Eastern Standard Time. Watch for alerts on these future webinars, and I strongly encourage you to join us in the future with these webinars. Again, as Dave said, visit ifc.org/COVID-19 to find resources, the webinar we did from last week, and dashboards showing live impact updates. Finally, I'd like to say this is a challenge that our generation will be judged by. I have no doubt we will come through this. As I like to say, there's always a green light after the red light. I'm honored to serve in this noble profession with so many outstanding people who make a difference every day in their communities. Please join us in our webinar next week as we provide the latest updates and information. Please, everyone, stay safe. And thank you. And God bless you. And God bless the United States of America.